Hey everybody, this is Lisa and I'm doing my presentation on surviving sepsis. So sepsis is the leading cause of death in hospitals and the number is growing. Sepsis is responsible for 500,000 emergency visits each year, and seniors are 11 more times likely to be hospitalized with sepsis and more likely to die from sepsis. The overall mortality rate of sepsis is 40 to 60%. The cost and financial impact of severe sepsis in the United States each year is huge. Treatment of sepsis often involves long-term care in a hospital. The Agency for Healthcare Research and Quality lists sepsis as the most expensive condition treated in U.S. hospitals, costing more than $20 billion in 2011, and that number is rising. Studies have proven that early diagnosis and treatment of severe sepsis saves lives by decreasing morbidity and mortality. Let's talk about some definitions. The first is the Systemic Inflammatory Response System, or SIRS. SIRS is the body's nonspecific response to an infection, trauma, burns, or any insult that causes tissue damage. SIRS is classified as two or more of the following criteria: hyperthermia or hypothermia, tachycardia, tachypnea, elevated or lowered white blood cell count, and bandemia. In order to meet the criteria for sepsis, you must meet the criteria for SIRS plus have a documented source of infection. Severe sepsis is defined as sepsis plus at least one organ dysfunction, such as a kidney injury, low urine output, elevated LFTs, arterial hypoxemia, or coagulation abnormalities. Those are just a few. The definition of septic shock is the presence of the previous criteria, including a lactate greater than 4, severe sepsis, plus a persistent state of hypotension that does not improve after an adequate fluid challenge has been administered. Now we come to MODS. MODS is multi-organ dysfunction syndrome caused by severe sepsis. A patient with MODS has multiple failing organs secondary to the setting of severe sepsis. Mortality from sepsis rises from 75 to 80% when 4 or more organs fail. Sepsis is a continuum. It begins with the early symptoms of SIRS, then add an infection, which makes it sepsis. At this point, if the patient does not get treatment, the infection will progress and the patient will experience global tissue hypoperfusion or end organ damage, which then escalates to organ failure, which then escalates to hypotension and septic shock. In 2003, the Surviving Sepsis Campaign, along with the Institute for Healthcare Improvement, published international evidence-based guidelines to manage sepsis, which included a sepsis bundle. The sepsis bundle has been updated since the initial publication. It was updated in 2008, in 2012, and again in 2015. In 2015, the bundle was updated again. It's divided into two bundles with a goal of a 25% decrease in mortality rates. The two bundles are divided into a 3-hour bundle and a 6-hour bundle. Sepsis is now considered a time-critical illness, the same as a patient that presents with an acute MI or a trauma patient. The sooner these patients presenting with sepsis are treated, the better the outcome will be. The Surviving Sepsis Campaign 3-hour bundle consists of 4 parts: the patient's lactate level, blood cultures before antibiotics, broad-spectrum antibiotics, and a 30 ml kilogram per kilogram bolus. In the presence of septic shock, the lack of oxygen delivery to the tissues decreases cellular metabolism, which then increases cellular lactate production, which eventually diffuses into the blood. If your patient appears sick enough that you want blood cultures, a lactate acid should be drawn as well. More often than not, a septic patient will be much sicker than they look. A serum lactate level will help you identify those patients that don't present as sick as they truly are. In the first few minutes of assessing your patient, deciding if this is a patient with an infection that is controlled or a patient with sepsis or severe sepsis, drawing that early lactate acid will help determine very early on how you will medically manage this patient. It's important the blood cultures and all other cultures are drawn before antibiotics are given so that the organism can be identified. The reason for early identification of the organism means that the antibiotic that the organism is sensitive to can be initiated, and the broad spectrum antibiotic can be used less, which will avoid increasing resistance to antibiotics in the future. Even though the 3-hour bundle recommends antibiotics within 3 hours of triage, the guideline actually states that antibiotics be started within 1 hour of recognition of severe sepsis. Every hour that antibiotics are delayed in a patient with severe sepsis increases patient mortality rate by 8%. The initiation and administration of antibiotics as fast as possible is one of the most important things that can be done in the survival of severe sepsis. The guidelines recommend giving a 30 cc per kilogram of either normal saline or lactated ringer bolus as fast as possible within 1 to 2 hours. Volume resuscitation is the most important part and will make the most difference saving organ function. Managing severe sepsis is a team effort, and with the urgency in treating patients with severe sepsis, knowing that every hour that goes by, mortality goes up, it's important to have a multidisciplinary team that includes providers from all departments, including nurses, doctors, respiratory therapists, and pharmacists. The pharmacist can quickly provide antibiotics and also prepare other medications, such as vasopressors if needed, to help maintain blood pressure. Other important pieces of the sepsis protocol should include staff education and red flags in the EMR that notify nurses of out of normal range lab values and vital signs. Staff needs to be taught to respond to sepsis alerts the same as they would respond to an acute MI. The 6-hour bundle consists of 4 main parts. The first and most important is to make sure you have a mean arterial blood pressure of 65 or greater using vasopressors. Vasopressors are initiated if the fluid bolus that was given did not bring the mean arterial blood pressure to 65. The guidelines state that vasopressor treatment should start with norepinephrine. If that does not keep the mean arterial pressure at goal, then to add epinephrine. The placement of a central line and art line are done at this time. This step involves hemodynamic resuscitation for patients that remain consistently hypotensive with a MAP below 65. This step involves fluid resuscitation as well as vasopressors to maintain a CVP of 8 or greater and a mixed venous O2 saturation of greater than 70%. If the initial serum lactate was elevated, you're going to want to recheck that lactate again during the 6-hour bundle to ensure that you are making some progress in the resuscitation of the patient and verifying that organ ischemia is not ongoing. And that's all I have. Thanks for watching.